It's my pleasure to introduce my colleague and friend, Dr. Nadine Gracia, who will be moderating the panel that will be coming up next. Maybe I'll ask the panel members come up while I introduce Dr. Gracia, so please, panel members, come up. Dr. Gracia is the Executive Vice President and Chief Operating Officer at Trust for America's Health. She is a pediatrician, a clinical expert, but she's also had extensive experience in senior roles in the federal government, in professional associations, and academia. She's a remarkable national leader. Prior to joining the Trust for America's Health, Dr. Gracia served as the Deputy Assistant Secretary for Minority Health in the Obama administration at the Department of Health and Human Services, and she was previously the Chief Medical Officer in the Office of the Assistant Secretary for Health. So please join me in welcoming Dr. Gracia.
I'm going to do a quick mic check. Can you all hear me okay? Okay, wonderful. Good afternoon. It's such a pleasure to see all of you here this afternoon. Thank you so much for your support and interest in this work on promoting health and cost control in states. This initiative is truly an important one, and one in which you've heard from several of our speakers earlier how important and timely this is. We have really a great panel of colleagues and longtime partners of Trust for America's Health, or TIFA, that we're really excited to engage in this conversation. We're going to have this conversation and talk about a few of the issues, and then leave some time for you all to offer any comments and as well as ask questions of our audience. And forgive me if my echo, I will moderate appropriately. So first, let me start with introducing our panel this afternoon. First, to my left is Dr. Anand Parekh, who is the Chief Medical Advisor at the Bipartisan Policy Center, where he provides clinical and public health expertise across the organization, particularly in the areas of aging, prevention, and global health. Prior to joining BPC, he completed a decade of service at the U.S. Department of Health and Human Services, where we first met and had the opportunity to work together. As an internal medicine physician, Dr. Parekh served as Deputy Assistant Secretary for Health from 2008 to 2015, and during that time he developed and implemented national initiatives focused on prevention, wellness, and care management. And we are also thrilled that he served on the advisory group of the FCPP initiative for this report, and greatly appreciate his expertise. Next, we have Dr. Nguyen, who is the Deputy Associate Director for Policy and Strategy at the Centers for Disease Control and Prevention. In this capacity, he supports the policy agenda across CDC and manages the CDC's efforts to promote collaboration between the public health and healthcare delivery systems. Prior to joining CDC, Dr. Nguyen worked as a senior advisor at the Center for Medicare and Medicaid Innovation, focused on population health and value-based payment initiatives. He's a primary care provider who continues to see patients at a federally qualified health center. And our third panelist is Dr. Mike Fraser. He is the Chief Executive Officer of the Association of State and Territorial Health Officials, or ASTO, the national nonprofit organization representing the public health agencies of the United States, the U.S. territories and freely associated states, and Washington, D.C. Dr. Fraser has been advancing ASTO's mission as an advocate, voice, and resource for state and territorial public health since 2016. And prior to ASTO, he served in many leadership positions, including Executive Vice President and CEO of the Pennsylvania Medical Society, CEO of the Association of Maternal and Child Health Programs, and Deputy Executive Director of the National Association of County and City Health Officials, and he also served in various capacities at the U.S. Department of Health and Human Services. So it's my pleasure to welcome you all to this briefing, and again, thank you for being willing to talk to us about the importance of this work, and in particular the role of policy in promoting health and well-being, in particular at the state level. You know, we've heard already the timeliness of this work, and in particular in thinking about the number of new governors and new state legislators who have come into office and who are really setting forward their agendas as it relates to health. And so from your vantage points, each of you intersect certainly on this issue nationally and at the state level. It would be wonderful for you to share, what are you seeing already as some of the trends, some of the emerging trends and areas of focus that are happening in the states and where there may be some opportunities for this type of work moving forward. Start.
Well, Nadine, first off, again, congratulations to TIFA. This is fantastic work, extraordinarily important for policymakers across the country. And I think it was great to hear from state representatives as well. Very, very inspiring. I think there's a lot of activity at the state level right now. Of course, states are trying to increase access to health insurance. It's not just blue states trying to expand Medicaid, but also red states looking at ways to perhaps partially expand Medicaid. There's a lot of activity looking at controlling costs in the state Medicaid program, which is a big portion of state budgets. But I think there's also quite a bit of interest in the social determinants of health and integrating health and human services, both from blue states and red states. And I think that's where this report from TIFA comes into play. I think if you're a blue state or a red state, whether you're a Democratic or Republican governor, a Democratic or Republican legislator, there is something in this report for every state. And I think I was also pleased to see out of the 13 recommendations, all are very, very important to improve health and potentially reduce preventable healthcare costs. Many save lives. And what can be, there's nothing more important for a governor or a legislator or a public servant than to protect and save lives of the citizens that you're serving. And I think that is a critical message here. This is a playbook, a guidebook, a menu of options to save lives, and I think that's tremendously important. And I think the last thing I'll say, Nadine, just to start off, is I think not only is this timely, given your point of new governors, but also I think I'm trying to remember this last point, which was a good point here. I might have to hand off to Vaughn, but let me hand off to Vaughn, and we'll come back to you. It was a good point.
Yeah. On that note, I agree with much of what Anand mentioned, but let me start off with actually just a story. So when I think about this report, it's not just 90 pages and 1,500 references, although Adam, I am thoroughly impressed. So, no, this is also very personal too, because I actually remember growing up and getting free and reduced lunch. And that was something in my life at that time where it did actually provide me with nutrition to be able to get my education. And now, not just as a child, but as an adult, I every day, like my daughter just turned 5 on Wednesday. She let me know that she turned 5 because I forgot the present. It was terrible. But what was more important than that is actually when we picked her up, she was part of an early childhood education program that's available to all the residents of Georgia. And so it truly is a bipartisan issue, this idea of educating children and recognizing that it has impacts on health and education and so many other sort of aspects of your life later on. Going back to the original question of where the impact is, I agree that the social determinants of health are sort of one of the places, one of the big opportunities, as there is value-based transformation, as state governors as well as legislators think about improving the health of their communities. There's a recognition that it's not just healthcare, not just public health, but also thinking about housing, thinking about the economic aspects of that. Lastly, I would say the other thing I think that provides an opportunity for this report is that it's not just about health, it's about controlling cost. And despite being in an economy where there is almost basically full employment and very reasonable growth, there's still cost pressures. And that ability to not just know if I'm going to be implementing this program, not only will it help improve the health of my population, but it'll help me control my state budget. It's a critical aspect of and a power associated with FCPP.
Great. Well, thanks again for the opportunity to be here. And you mentioned the new governors. So we had potentially 39 gubernatorial transitions in November. Not all of them switched. Some of them were reelected. And we have 23 new secretaries of health that we're currently in the process of orienting to that really important job. And one of the things I would say off the bat is it's not just the Secretary of Health that's new. It's going to be the Secretary of Housing. It's going to be the Secretary of Economic Development. It's going to be the Secretary of all the Education. And so this transition is important because if we're going to talk about linking sectors, which is what's really required to get this work done, everybody's got to be part of that. And so one of the insights that we've had, again, it's not rocket science, but is this multi-sector approach to health. And that I think what's striking about the report and the 13 interventions is that most of them have nothing to do with the classic, tertiary, secondary prevention, public health approach, and in fact, are moving us down the pyramid to this primary prevention that has lots to do with social determinants and a lot less to do with what happens in an exam room. And I think orienting all these leaders to that perspective is important. We take it almost for granted in public health, but it's not necessarily obvious to many folks how the places we live shape our health, and we focus so much on healthcare. So I would say that's super important. The couple other observations just to start us off, none of the elected officials today receiving their awards, you probably wouldn't know what party they're with. There was a Republican mixed in there. And so I think when we get to this level of really looking at what's important, it's an opportunity to be together. It's that bipartisan or nonpartisan approach. That being said, I'm really glad TIFA did this work and not us. Because as a group of states, there's a lot on that list that many of our secretaries of health would have a hard time being vocal about supporting. And so while I was initially really miffed that TIFA got that contract or grant, it makes total sense. I also realized there were so many. I'm so glad we didn't have to do it. My staff would have walked away fuming. But it really does show that we've got lots of opportunities here. But I think what Secretary Neal said, the two things he said was important. One was look at where we've come in terms of I never thought about a 10-year-old never being exposed to smoke or, growing up flying in an airplane with people smoking. Oh my God, it's just horrible remembering that. But also that, this is really a nonpartisan issue when you look at why people do this and really thinking about that, what that means for our work. He did say this work is political. It's very political. And even something as evidence-based as syringe service programs is a flashpoint. And there's so many of those. There's just so many of those. Why some of those things are so politicized, we can talk about on the panel. But I think, the fact that some of those states have done 13, 12 of the policies on lists is pretty amazing. I hope some of those governors run for president someday.
Yeah, please.
So Mike has not surprisingly triggered, I think, the third point I wanted to make, which is about health in all policies. And you can imagine taking this report to the governor's office, and the governor's office saying, well, this is good, but why are you here? Why don't you go talk to my state health department or my state Medicaid agency? And that is the teachable moment, I think, that's so important about this report. Health is derived from all policies, and every single department, as Mike says, has a critical role in implementing these policies. And I was very happy to see that the policies that you have selected span economic development, education, housing, transportation, infrastructure, and I think that is the critical teachable moment, that the health department is critical, the Medicaid agency is critical. But for states to really provide that leadership, it has to be the governor, the governor's office, and that leadership has to be required across the entire government. And I think that's a really, really important point, and I hope that governors really see their central role and responsibility here.
Yes, please, Mike.
And I think that's a different competency set for a lot of folks that are leading in health right now. And when I look at this, I obviously see a lot of these could be governors' initiatives, but it's really going to be the state houses and the general assemblies and all of the goes on in the 50 state capitals and 9 territorial sort of capitals. And the state legislators, I mean, look at that group. It ranges from physician experts to real estate agents, and all of whom can be on a health committee, all of whom are going to be lobbied by medical associations and hospitals and non-for-profits, and really have to be very fluent in the social determinants in a way that it's not intuitive to a lot of people, especially those that don't experience the disadvantage or challenges that many Americans do. And so I think that it's incumbent on us to not only put the 13 policies out, but then start to think about, so what does this look like in terms of implementation and in different contexts? the Rhode Island director mentioned the work they did in health equity zones. And what a tremendous compliment to Nicole, who's the Secretary of Health and runs that program, that her colleague was that fluent in the health equity zones. But also, I think about the health equity zones and what they're doing in Rhode Island, and it's really about communities getting engaged, communities saying what they need. The state serves a role in aligning assets to those priorities, some of which have nothing to do with health per se, but they of course do when you look at that and look at the report. But then you think about, okay, so let's replicate this model. There's evidence that it's working. Well, you can't go to some other state, I'm not going to say which, there's many of them, and say, let's do health equity zones in this state. I mean, they're like, what are you talking about, equity? That's socialism. We don't do that here. But there's similar ways of doing that with a different lens or a different, a synonym. So, there's a initiative in Arkansas called Hometown Health. Same thing. It's a place-based initiative to look at wellness, obesity prevention, healthy living. It's run by the state health department, but it doesn't take. You got to nuance that, and you got to do that in lots of different ways. And I thought it was really important to note that DC as a city is leading, because a lot of this happens in cities. If you look at syringe exchange, you look at some of these other more progressive quote unquote policies. Those are happening in cities where there's lots of folks thinking about this in the political well. And my worry is, how do we really translate this across the country into places where it may not be so easy, and the population may be disenfranchised, or this really isn't on their minds. They're, getting a job is more important, and so I think that's also the reality of this report and what it means for us and our members.
Each of you touched on and talked about, the nature of this being really addressing across sectors, and this being a multi-sectoral approach. It's addressing the social determinants of health. And you started even providing some examples. And we know in reality that so many things work in silos. And so when we say that this is an important approach really to being able to improve health across the state and control costs, what happens is there may be agreement to that, but then in practicality to actually do it, it can be challenging. Anand, you talked about the role of the governor as conveners. You're talking about other agencies being involved. What can we do to really make that process easier? Because if they see promoting health, yes, it may immediately go to it's the state health department that has to do it, and then they shoulder the burden of trying to convince others to be able to engage with them on this. How can we make this easier such that everyone sees their role in advancing this type of policy?
So let me start with this one. So from our experience at CDC, we run across this a lot, where we are the health agency or public health agency of the country. And simultaneously, we do want to work with multiple sectors. What we've found is that actually the evidence itself is a good conversation starter, because it allows us to begin to speak the language of the other sectors. So when we begin to talk to housing, really having a discussion about, well, with these loans and grants, not only do they help your population, but it also improves the health of the clients we're trying to serve in a meaningful way. The same applies with many of these educational policies as well. When you think about children, it allows us to talk to the Department of Ed and have a meaningful discussion. The reality, I think, is even though we are siloed, particularly at the federal government with our various departments, when you are living in a community, you're not siloed. If you're thinking about transportation, for instance, that bus that gets you to your medical appointment is the same one that gets you to work, the same one that gets you to the grocery store, the same one that gets you to your child to school, and recognizing that that while there are silos in terms of how we operationally work at different levels of government, or even in the private sector, for a person who's living in communities, is very different. They experience it very differently. And that provides, the evidence actually provides an opportunity to show how you can affect multiple aspects of an individual's life in a meaningful way.
Yeah, I would totally agree with Vaughn. Now, we got to remind people, the reason Vaughn forgot his daughter's birthday was he just hosted 400 of us in Atlanta the last 3 days. So I think you get a pass on that. But, at that meeting, there was, yeah, no, it's a good thing to know for you. At that meeting, there was folks from all over, and silos be inside of silos, right? Just in terms of their professional affiliation and the work they do and the specialties that were comprised of in the room, 400 people or whatever it was, 200, I don't know. And the insight that I think the group that I gleaned from the group, there was lots of them, but one of the things that I used in the wrap-up yesterday was nobody wants to pay for glue, okay? So everything we do has a funding stream and an advocacy group and a line in a budget, and that's really how you get what we have today when it comes, at least to a state government, and I'm not just talking about health departments. And the investments to do a lot of this work are federal. There's not a lot of general funds in states to do much anything other than Medicaid and education. But nobody wants to pay for the glue that would hold those multi-sectors together. And in fact, there's some truth and some myth about why those things can't actually work together. And so we need to start thinking about what is that glue? What is that thing? What is that role? What is that function that crosscuts? And in many places, it's a policy person in a governor's office, and I think that's great. There aren't enough of those, though, and they got to be within agencies. And I think what we've done in public health, at least, is ask people who are already really busy doing the up and down in their silo to start doing the across work, and they're like, "There's only 24 hours in a day. You're not giving me another 4 hours to do this." And what I'm responsible for is actually going up and down in this silo and then sending the report up to CDC that we actually did it. And this other stuff you're asking me to do, well, I don't have time for that, or that's I'm not giving them any money, so why would I talk to them? And so really thinking about, where we're moving in terms of population health is to cross-cut. And so there's these interesting new jobs I think we're going to see in healthcare, which are people who sit in clinic and then actually go out in the community, aka community health workers, right? People who are going to be able to take this much bigger approach to health, really be fluent in what's happening in their community, and that's their job. It's not the nurse that's got the Xerox sheet that the nurse left before her about who to call when you have a patient with substance misuse. It's someone's job to know, real time what services are available. And I think that's really interesting, and it's going to help move, I think, us into the community where all of this is really happening. And I'm excited about that.
I think one of the things the federal government needs to work on, I think that can help bridge these silos, is the blending and braiding of funds. So you think about health and housing, and blending is essentially taking funds, putting them all in one pot. Braiding is taking various streams of funds. But you think about health and housing, how do we make sure that rental assistance subsidies going to a particular vulnerable population is matched with Medicaid funding to provide healthcare services in a congregate setting for that population? So how can the federal government do a better job bringing these silos together by bringing these funding streams together? And I think conceptually also, ultimately, the solution to what we call the wrong pocket problem, somebody spending dollars here but not seeing the difference that's going to another sector, is essentially, at the end of the day, there's got to be something for everybody here. And ultimately, if you can provide shared incentives and shared savings, if there are savings, ultimately I think that's also a powerful way to bring sectors together.
Excellent. So in that vein, and Mike, to your point, you talked about also this issue of equity as we think about these policies. And as was talked about in the introduction of the report and from our supporters, the notion and the understanding that equity as a principle was central to this work and to this initiative in ensuring not only are we looking at policies to say, is there health and economic evidence, is there opportunity for state legislative action, but can we see that this policy can actually help us in addressing disparities and actually working to advance equity. But that can be seen different ways, right, across the states, and how do we get to an understanding, if you will, about this notion and this understanding that as a value and as an implementation principle, that everyone having an opportunity in the role that states have to ensure that everyone has the fair and just opportunity to reach their full potential for health and truly reaching health equity is part of that framework and that implementation of these policies and others that states may be considering.
So when I think about health, actually, and trying to think about that, I think you have to measure. To actually understand what the challenges are, you have to begin to measure them, and you have to be very public about reporting them. The example from CDC is when there's been a big push to think about rural health and rural communities in a meaningful way and to understand what we can do to support those communities. So there was a series, Morbidity and Mortality Weekly Report series, where CDC put together studies looking at rural versus economic outcomes. And this was done about a year and a half ago. And when you look at the 5 leading causes or preventable causes of disease within this, in all 5 of those, rural communities had worse outcomes. And that ability to measure was critically important. One, we should have looked at it sooner, and the numbers were there, so that would have been one opportunity. The other thing I think what we found is that when we produce those reports, and as we've spoken to rural communities, it would have been great if it was earlier, but it's so wonderful that it's there. Now those communities are able to take that to the representatives, to the congressmen and women, to their governors, to their local representatives, and say, hey, this is a challenge within my community. It is impacting me worse than X audience over here. What can we do about it? And then it allows you to drive this cycle of continuous improvement on that. But that ability to measure and systematically and be intentional about health equity is critically important.
I think some of the policies in TIFA's report, take paid family leave. We're the only industrialized country in the world without a national paid family leave policy. Only 15% of employees of this country have access to a policy. But from a health equity perspective, less than 5% of low-wage or low-income Americans have access to a policy like that. And that's also compounded by what Gerda said. Then a lot of vulnerable low-income Americans don't even use that policy. So that's the type of, very pleased to see TIFA lifting up policies that at baseline relate to health equity, and those policies inherently, if we can adopt them, would tackle some issues related to health equity. I think there are other issues, for example, and some of these are not addressed in the report. You think of a soda tax. You think of soda portion caps. Some of the cigarette taxes, regressive taxes that disproportionately, one could argue, well, that's actually hurting a vulnerable population. And I think there we really need to flip the script by saying, actually, what these policies are trying to do is prevent harm and poor health in populations disproportionately impacted by a particular health hazard. And I think, Nadine, what that really entails is really important to these policies, how you implement them. You really need to work with communities. You need to build community coalitions. You need to build lines of trust with communities so you can go to these communities with empathy and have discussions about why some of these policies, while inherently they may be regressive, while inherently one may say on first glance they disproportionately impact a certain community, ultimately are critical to the health of that community because they're disproportionately negatively impacted from a health perspective. So I think a lot of these conversations, they require time, they require trust, but they're so important because ultimately you could have a great policy, but if you haven't built those bridges with communities, if you haven't formed the appropriate community coalitions, these policies may never be implemented.
So a core factor of moving forward in equity is that meaningful community
Absolutely.
engagement, not simply.
I think it's Friday afternoon. I think that the term health, we have inside language we use inside the house and the language we use outside the house, and stuff like health equity and social determinants of health. That makes a lot of sense to those of us who talk about this a lot. But I think if you talk to the person next to you on the train or plane, wherever you're off to, and the run-of-the-mill folks, they're not going to know what the hell you're talking about. And I went to this housing meeting talking about health equity, and they thought we were talking about investments and equity, like banking. And so, we've got to think about that language a lot, and there's great work done on framing and how you frame that. I think for us, it's health equity and the places where that folks can relate to that, and they have programs in that and job titles with that. But in other places, it's optimal health for all. I mean, what's more American than that? That's motherhood and apple pie, and that's about fairness, and that's about how our country was founded and what we're trying to sustain over time. Social determinants, that's a tough one. Again, it's tricky for people. So you have to talk about, what are the root causes? What are the things that really lay a trajectory? Those kinds of things, and it gets, it's tricky. But ultimately, I think we got to get there. We got to get there because, in state houses across the country, we're not going to see the same bill. We're not going to see the same language used. I also think that what's really important about what we saw this afternoon with the 3 states is this is not going to happen in Washington. Sorry, everybody. You know, I mean, I know we're all here for a reason, but there's not going to be a national strategy on a lot of this, that states are going to figure this out for themselves. If you like it or not, you know, that's who we are. That's the history we have. That's a political history of our country. And things get done 50 different ways. It seems silly to us who sit here in Washington, look across and say, God, there's a lot of inefficiencies. But, you know, by God, you go to a state capitol and there's a way they do it, and there's a reason why they do it, and there's a tradition as to how they do it, and that's what's going to happen. And so, you know, the fact that Rhode Island has the paid leave is pretty amazing. And there's probably some other states thinking about it. And that's going to happen a lot faster than anybody downtown, you know, here on the Hill that's going to do that. And I think that's the beauty of this report. It gives states that roadmap to think about, okay, well, if we want to get serious about this, here's the list of things that we should be thinking about. What does it look like for us in our state? Let's not wait for Washington to figure it out. You know, I think that's, I'm not running for office. I'm not bashing Washington. But I'm just saying, you know, working with the state group over time, I've really realized that, you know, this cliche about laboratories of innovation, you can take that however you want. It's, you know, laboratories of innovation, or it's the total basis for why we have discriminatory policies across the country that don't make any sense. But it is what that is. And so that's true for health, it's true for education, it's true for housing, it's true for all the sectors involved in this work. And for us to really be impactful, I think, is to look at that. And, you know, frankly, I go to a state to say, I don't care what Rhode Island did. It's a small state, it's on the East Coast. We're a mountain state. We've got same number of people over a geography, you know, 50 times the size of that state, and it doesn't matter to us, you know. You tell somebody that, well, they did this in New York, they automatically want to do the opposite in some states, you know, or Massachusetts. So, you know, I think that's just, again, the reality of what we face, and that's okay. It's just, we need, it takes a lot of work. You got to do it 59 times with the territories, which are very, very different.
If I can say, so I agree with Mike. I would probably add, while that is the reality, I think that anytime you can try to align policy efforts at the federal, state, and local, that will always help us accelerate to where we want to go. So, for example, in early childhood and care, we have seen some investments, increased investments in the Child Care and Development Block Grant, Head Start over the last couple of years. That's important. Paid family leave, there is some bipartisan interest in National Paid Family Leave Program. You know, health and housing, just yesterday, there was bipartisan, bicameral legislation introduced focusing on senior home modification assistance. How do you ensure that seniors have the ability to not only age in place, age with options? It's actually a recommendation that came from BPC's task force a couple of years ago. So I think Mike's point is a good one, but where there is an opportunity or a possibility where federal policy can support state policy, that will only accelerate, I think, the direction where we want to go. So yes, there is Washington dysfunction, but we should try to capitalize on opportunities where we can align federal and state momentum.
So both a multi-sectoral but also multi-level approach, right, as far as that type of implementation and the sustainability of that implementation. To Mike's point on definitions, what we're also saying, while there may be not the full understanding of social determinants of health outside of certain health circles or policy circles, what we're also seeing is that there seems to be, we've been talking about some of those things as access to certain needs and social needs that individuals may have. And we're seeing this movement, for example, in health systems and hospitals of increasingly trying to address more of the social needs of patients that are being served. But understanding that that's more of an individualized approach as opposed to what we're talking about here is at a policy level. And I know you all think about this quite a bit when we think about how do we advance policy to really improve population health. Help us talk a little bit more about this understanding. John alluded to this in his opening, that addressing the social needs in that kind of a context is important but not sufficient. And that really then, thinking about this from a policy lens and the broader social determinants of health and getting at root causes really can help us when we think about the more global impact that we're looking to have across states and ultimately across the nation.
I'm happy to start on that one if you want. You know, I think it's a really good observation. It's one that I did learn from John and was appreciated hearing more about this week. I mean, the clinicians' expansion outside the clinic into the community to think about the health-related social needs of their patients is great. Nobody's, you know, questioning that. But it's not systems change. So creating a food pantry in a hospital is great for a food insecure patient. But it's not changing the system that creates the conditions whereby that person being food insecure is the outcome. And so, you know, to think that, and I said this earlier in the week, to think that we can ask the health system to solve this problem is completely ridiculous and unfair, you know. And I think that's why policy solutions are particularly important. And those aren't necessarily going to come from a delivery system who has different incentives. I mean, that's something that we need to talk more about, I think. But at the very base, it's really only government ultimately that's accountable for changing these systems, you know. And thinking about what that looks like across the country is really important. But sort of medicalizing social needs, you know, fixing a doorbell so you get your medication when it's delivered, that's not changing the housing conditions. So all of these things are super important and really interesting, but ultimately they're addressing symptoms, not causes, in the language, I think, the vernacular. I mean, we spent, I don't know, 20 minutes talking about how Lyft is giving rides to seniors in the Medicare program for one of these health plans, and I'm like, that's awesome, and I'm sure, you know, my father would use it if he could use it, if he was on that plan that year, you know? But that's not changing the transportation policies or the experience he has as an elder trying to wait for the bus and wasting a day to get to a doctor's appointment and all that's involved in that. So I just think expecting the health system to do this is totally unrealistic. And it's awesome that they're thinking about this because we need them at the table and they play a huge role in health. But again, the systems change doesn't happen there, at least not in the systems that I've observed or experienced.
Let me leverage that comment about Lyft. That was just this is a conversation that just occurred in Atlanta, and my overall comment would be that it's not an or question, it's an and. So there's an opportunity to do both. But it was a really fascinating conversation where there was Lyft was working with an organization called Care More. And they were providing rides for individuals to get their hospital appointments. And it turns out the customer service was great. Like one of the complaints from some of these elderly individuals in the Medicare population was that I have to wait outside for an hour for this vehicle to show up. It's cold or it's rainy. And then Lyft would show up. And the contrast was Lyft would show up within a 5-minute interval, and you can actually see it on your phone. Sometimes they actually, for disabled patients, one of their challenges is sometimes they show up too quickly. And so the disabled individual's not able to get out quickly enough. So it's actually sort of a fascinating problem. And then there was, in contrast to that, on the stage was also the representatives from Grady Hospital or Central Hospital and MARTA, which is the public transportation system in town. And they had a slightly different model where they were providing vouchers through Department of Transportation funds for Rides to Wellness to get to provide these vouchers for individuals. They could take the train to the hospital, or they could take it to the grocery store, or take it to school. So two contrasting sort of approaches. And there was an interesting question in the crowd. It's like, well, I mean, gosh, you're solving Lyft, you're doing this for individual patients, but does it solve the bigger problem? And I was expecting that the folks from MARTA to say, no, Lyft, this isn't going to work. But the reality, what their answer was that, you know, they actually work together. So Lyft actually has an agreement with MARTA. And so what they do is for public transportation, it's really about getting people from area A to area B. And then subsequently, what Lyft does in its partnerships, they actually work with the last mile or the last 3 miles, whatever it may be, whether it be with a Lyft ride or a scooter that we're seeing everywhere in Atlanta. I don't know if it's the same problem in DC, but I trip on them all the time. But this gets back to that question of Ann. Really thinking about how you collaborate across systems and looking for solutions that really combine sort of multiple that pull people in from multiple sectors to solve a broader problem is quite important. And this is that cross-sectoral partnership that we talked about earlier. And another interesting comment is around social determinants is, well, I may walk into a room and call it a social determinant of health. Turns out when you walk into a conversation about transportation, they talk about social determinants of transportation, such as disability. So if you're walking into a conversation about housing, there are social determinants of housing and social determinants of education, social determinants of employment, and health is one of those things. So really this multi-sector approach and this and rather than an or approach is critically important.
I don't have much to add. I agree with both Vaughn and Mike. Social needs, critical that we address social needs, but it's a Band-Aid, right? It's somebody's food insecure, you give them food. Somebody can't afford their rent, you give them rent. But the systematic solution there is how do you ensure that there are nutritious, affordable options in the community? How do you ensure there's affordable housing? And we have a housing crisis in this country. 11 million Americans who spend more than 50% of their income on housing. 7 million Americans who essentially have 30% less than area median income. And there's a shortage of affordable homes of 7 million. So we have a housing crisis. So all of those things, a hospital and a health system on their own, they're not going to be able to solve that. And I think that's where policy comes in. That's where this multi-sectorial approach comes in. That's where this focus on determinants of health, working with other sectors comes in. So social needs, very important. Glad we're addressing social determinants, as Vaughn and Mike said, much broader and much more holistic way of solving some of our challenges.
Absolutely. Why don't we open it up now for questions from our audience? And we have a microphone, I believe, that we're going to be, there you go. Any questions or reactions, comments from the audience? We have one over here.
Good afternoon. My name is Jennifer White. I'm with the American Heart Association as one of our community advocacy directors. I have a question regarding the upstream issues, right? And I think a lot of times we know these things to be institutional racism, gender inequity, as well as wealth inequity, as well as power and privilege and the intersections of those concepts. But when it comes to these 13 policy priorities that were identified, as well as a number of other policy levers that can be identified paired with the appropriate evidence, how is it that we can specifically get to those upstream issues, those things that we don't like to name, as well as how is it that we can face the ugly history of those concepts, and how is it that we can make sure that we're being more intentional about building that within the policies as well as the process in the advocacy process?
She started with an easy one.
Yeah, that was, I think we've got to name it. I mean, I think that's something that's really important. And there's a reason why we see some of the worst health outcomes in the country in a particular geography of our country. And that has to do with the history of the Southeast in particular. Not that doesn't exist everywhere, I'm just as a focal point. And I think we have to name that, and that's racism, that's institutional racism. It's folks who have a legacy of not trusting the system that they're being asked to access. So we could build all the clinics we want if those providers aren't thinking about that history and how to approach that in those settings. It's not going to work. I think there are some pretty interesting changes going on out there, and I think this is the long game. I think this isn't going to be we're not going to see this in 2 years. This is generational. I actually talked to some of the health directors in the Southeast about the disparities in health status. I talked to them about who works in their agencies, which is really interesting to look at, demographically. And that's changing, but they're in it for the long game. They're thinking 20 years. They're not thinking the next year's grant report they're going to have close the gap. They're thinking 20 years ahead. And I think that's an important approach to take. But I also think these really honest, authentic conversations with communities have to happen. And that's where government is ill-equipped in many ways. When we surveyed health commissioners about their ability to feel prepared in having conversations about racism and engaging in conversations about health disparities. Some work we did with the Kellogg Foundation and other partners, they felt that they needed a lot more help in that area, because that's not something that you don't get that in medical school, you don't necessarily get it in MPH school, and they really needed that to be effective. The other solution to that is something that's really hard for a lot of us, which is assuming that we don't have the answer to the problem and instead have to ask. And I think that's the beauty of what's happening in Rhode Island with the health equity zones. I mean, it's really all about asking and engaging in an authentic conversation versus coming in and saying you need to do these 13 things. You know, if we were to take this list and go in and say, these are the 13 things you need to do in the East End of Washington, D.C., they'd be like, okay, here we go again, right, in that neighborhood. And so I think we have to have a different way of engaging in those conversations. And I mean, you know this if you're working in the community, you know that that's a lot of work, you know, and that takes a lot of time, but it ultimately is what we have to do to see progress from my perspective. And again, expecting a health department to do that alone or a hospital system to do that alone, I think it's not realistic.
Yeah, and what I might add is that towards your point, you have to be very intentional about this. So frequently we talk about health equity at the end of the conversation as opposed to the very beginning. So when you begin to build those cross-sector partnerships, making sure that it's highlighted as something that you need to address throughout the course of any policy you may write, and not just, gosh, what about this population at the end? So that's critical in terms of those conversations.
And I think we need to continue to do a better job educating policymakers about this issue. I'm going to be honest with you. Prior to reading TIFA's report, I knew nothing about ban the bucks, you know, and now understanding the stories, the literature, the data, and the evidence, you can see how negative this could be for families, for populations, and I'm heartened to see a lot of the bipartisanship around criminal justice reform in this country, particularly also at the federal level now. But I think it's policies like that, and I think the more we can do educating policymakers on both sides of the aisle, I think the further we'll get.
I would just add to the long game approach is having that long game approach, but with a sense of urgency, because these disparities also did not arise, you know, overnight. We have been in the long game for such a period of time that having that sense of urgency to saving lives, to understanding the fairness and justness, I think is critically important so that we can understand how policy actually can have sweeping effects if implemented, measured, engaged with the community, can actually have sweeping effects to be able to correct those inequities. Other questions? Anyone here?
Good afternoon. Ursula Bauer from the Office of the Surgeon General. Thanks for a great discussion here. So a couple of books have been written about how Americans vote against their own self-interest. And businesses can often see very clearly what they're spending on health care for their employees. And they think they can see what some of these policies like paid leave, paid parental leave, higher wage, and so forth would cost them as a business. But they're not seeing, individual voters, consumers are not seeing, and businesses are certainly not seeing what the cost of the status quo is, right? What not having all of these policies that lead to the poorer health, the poorer educational status of Americans is doing to our health and to our opportunity. How do we correct that? You know, how do we help the voters see what the cost of the status quo is and what the opportunity these kinds of policies present? And how do we build demand to our policymakers to actually implement these kinds of policies?
Well, I'll start, and Ursula, just thank you for your leadership on so many issues at CDC and now at the Surgeon General's office. And I know this is an issue that's very important to the Surgeon General. And I think the first answer is to frame it exactly how you framed it, And I don't think we do a good job there. Take the earned income tax credit, which is one of the 13 policies, that can actually increase sales for businesses. I think we need to frame it that way. So what are the opportunity costs? But I think that there's a real opportunity here to bring the business sector on board, and I think both politically as well as the fact that they see it not only important for their employees and productivity of their employees, but also to expand their consumer base. However vibrant the community is, that only helps a business. So I think we need to do a much better job explaining how important it is for them to go beyond worksite wellness and to actually try to improve the community's health, because it's really a win-win for businesses. I think, to your point, we need to do a better job from a communications perspective, framing this for businesses in a way that we haven't done so to this point.
Want me to?
Yeah.
So, if I knew that, I think it really is an important question. There's the interesting thing I've learned is that not everybody sees the world the way I do. And I think what's important is that we all have a different, you mentioned framing, we all have a different way of making sense of what's going on around us and what's important to us. And thinking about what drives somebody to vote against their interest and to think and be able to reconcile that cognitively, I think is really important. And there's heuristics we do that make that happen. And I mean, I'm not a neuroscientist, obviously, but the issue is really about how we view the world and what's important and the way we make decisions, and there's a salience about that. And so I think that's why we see a lot of these social issues being leveraged politically, because that's been exploited. And we just have to make that clear. Not everybody really cares what the evidence says. That's not their number one reason for getting up in the morning. In fact, they have other things that they are concerned about, like, they care about what's for their family or for their whatever. And so that becomes more salient to them. And there's all this stuff about moral foundations theory I've been reading because I was interested in this question. And there's a book with elephant in the title, and I forget which one that was. But it's really about, how that's been leveraged politically. It doesn't have to be that way, but we have to kind of undo that way of thinking. And so we're trying to, look, there's really 535 people that I want to get to think a little bit differently about health. They all work down the street. And they all come at this with those different heuristics, those different ways of making sense of the world because of where they come from and how they, what they're here to do. And so we've got to play to all of that. And there's some dominant ways they do that. There's some dominant ways that they think the world should be, the way what government should do and what it shouldn't. And, cost control is not necessarily the driver for a lot of people. There's other things that are more salient than that, and we need to be better about that. Clearly, they're not reading our reports. And we've got to understand why and then kind of put that into a language that will resonate. And maybe that has to do with some things we haven't figured out yet. But I'm excited about that opportunity because I think that's how we're going to be more effective.
What I might add to this is that I agree with both Anand and Mike in terms of I don't know the answer. I think there is a large communication component. But the premise that you brought up, people doing things that are against their best interest, actually, I think that's the value of policy, and specifically some of the policies in this report. Take complete streets, for instance, right? So it's easy for me to go downstairs or in Atlanta to hop in a car and not walk enough. But by a complete streets policy, creating ample opportunity to make the healthy choice, the easy choice, you actually create an environment which I want to walk. It's very easy to go downstairs to walk. There's a sidewalk. There are many neighborhoods in Atlanta where I get out on the street. There's no sidewalk. Do I hop in my car to walk to the grocery store, or where it's safe? I know it's relatively safe. Or do I risk walking along the side of the street where there might be someone driving like me, which might put you at risk? And so the idea of people not making choices that are necessarily good for them, when we think about policy, there's a huge opportunity there to really reframe and create those opportunities for folks to have a default choice that is healthier for them. And many of the interventions that are identified within the report do exactly that.
Yeah, I will say that I'm very pleased that there was an economic section under each policy, because I think, Ursula, back to your point, that helps build the business case. And businesses are going to want to know tomorrow, will I be able to keep the lights on? So the data there, that if you're a restaurant or you're a bar and you're looking at a smoke-free policy, the first instinct is, oh my gosh, well, that's going to take away all my customers. I'm going to go out of business. But no, the evidence doesn't say that. In smoke-free policies across the country, workplaces or bars and restaurants, and you've seen a lot of the sort of restaurant sector come on board because they see this is actually good. It doesn't necessarily reduce their customers. They have more customers. It's healthier for their employees. So I think building that evidence is just so critical, and getting the business sector engaged is so important.
We're going to try to squeeze in one final question from the audience. I see a hand over here.
Hopefully this should be quick. Amelia Aria from the School of Public Health at the University of Maryland. We've had a lot of trouble trying to work with school systems and the educational sector and get them to connect with health-related problems. One of the major barriers is the confidentiality issues of joining health and education records, and they see that as problematic. Have any of you been successful in trying to address or frame that problem?
What I understand, and again, I'm not an expert, I guess that's why I was invited to be on a panel, that there's a myth and a reality to the barriers around data sharing, and it's easier to believe the myths. The reality is that these are not technical problems, these are people problems, and really thinking about, at least on the healthcare side, sharing data makes a lot of sense once people figure out how to do that. The places where I've seen this happen, and the driver, the urgency, has been around the opioid crisis. So states have passed legislation to mandate that, at least within state government, data are shared. Massachusetts is an example that everybody turns to. They're able to pull from different governmental departments to look at a person, a resident, and sort of track back their social autopsy is what they call it for opioid decedents. But it does take a little bit of political will at the state level. Now, there are federal rules that everybody turns to as well. Those, while complicated, don't make it impossible. And I think I have heard this is an issue, particularly with education. And I'm not exactly sure why, but you're not alone in that. But I mean, certainly can think about where there's resources for that, because I know folks have overcome it. I don't know if you have many specifics from your side, but I've heard that one. But that was a while ago, so I think some folks may have figured out what's really the deal there.
Right. So I don't have experience with educational data, but this comes up frequently between healthcare and public health on a very regular basis. The two specific legislations are HIPAA and 42 CFR.
Yeah, 42 CFR.
Which is the behavioral health data record. Mike's point is right. It's this question of the difference between myth and reality. And it comes down to the data you actually need versus sort of the broad context of the data that people want. And the more discreetly you can name the data you need, the more likely you're able to create a data use agreement that you can actually implement in a reasonable way.
There is one caveat to that. There are some data that are super protected. They usually have to do with mental health, psychiatric care, where there are some really clear firewalls to sharing. But overall, especially if you don't need identified data, that's not something that should be hard to get.
And I'll just close with, just in the interest of time, I'm happy to speak with you and others that may be interested. TIFA actually has a partnership with the Healthy Schools campaign focused at state-level policy implementation, bringing the education and health sectors together. It started as a federal initiative on increasing access to services utilizing Medicaid, school-based services, as well as supporting safe and supportive school environments. And so the state teams are formulated of state education agencies and state Medicaid agencies, as well as local school districts, really working to address some of those issues that you've described. I'm happy to talk to you afterwards as well. Well, we are at time and certainly want to thank our panelists for really a great discussion and conversation about not only this FACCS initiative, but really the importance and role of policy at the state level to improve health and well-being and control costs in states. And before we all leave, I want to bring up John, who is going to do some closing remarks, but please join me before we close out in thanking our panelists as well.
Well, I just want to say, what a great panel discussion. Weren't they great? And really, I think what your discussion illustrated was, working on these policy issues requires some really complicated and deep discussions, and that they're important discussions to be having, both at the national level and each state. As states consider the policies that are within the FACCS report, I think there are going to need to be lots of very customized, region-based, state-based conditions, to your point about what do these mean in our setting? How do we think about adopting these or adapting these so that they really fit into the situation we're facing? Thank you for that. I also want to say thank you to all of you for coming today. We are delighted that there's been the interest that there has been in this report. This is not a report, but an initiative. It's beginning. We want to work with all of you and think with you about how can we advance the health of the nation by supporting policy change at the state level.